Not tennis gaming, but yeah. So the first is supposed to be 15 minutes. That's for the
Is that, oh. We're going to go ahead and get started for session 4. Our first presentation is Connor Dillon, speaking about in-person interview as sine qua non for fairness and success of candidates applying to surgical residency, a 3-year pre-interview survey.
Good morning. So yes, my name is Connor Dillon. I'm a surgery resident at Western Michigan University. I have no disclosures. So following the COVID-19 pandemic, there was obviously an abrupt change in how everyone conducted interviews, but in particular surgery residencies. And we primarily switched to a virtual format. The AAMC still recommends the virtual format, and they cite reduced cost, enhanced equity, and a minimized environmental impact as factors influencing that recommendation. There's obviously clear benefits and downsides to the virtual format. And in response to some of these concerns, some programs have shifted to a hybrid format where both in-person and virtual options are offered. This has been met with some unease, the concern being that applicants who can afford in-person will select that format and potentially bias against those in lower socioeconomic groups. In 2023, our group reported a prospective analysis during a single application cycle. We found that candidates with a preference for virtual format were more likely to be female, attend a more distant medical school, had higher USMLE scores, and better letters of recommendation. The present study expands on our prior work by examining 3 consecutive application cycles. So applicants to our program, which is a university-affiliated general surgery program, for the 2022 through 2024 application cycles, we're given the 5 options listed here. And then we stratified groups based off of whether they had a preference for in-person or a preference for virtual. Applicants selecting no preference were excluded from statistical analysis, and then standard data from ERIS applications relating to the applicant's characteristics and academic performance were collected. Continuous data was analyzed with independent t-test and Mann-Whitney test. Categorical was analyzed with chi-squared and Fisher's exact test, and then odds ratios were determined using a logistic regression with virtual interview preference as the outcome and candidate characteristics as the independent variable. So over 3 interview cycles, we had 283 applicants that were offered an interview. Of them, 257 were included in our analysis. That was excluding the individuals who selected no preference. The left-hand figure shows the frequency of choice selection over the cycles, whereas the right-hand figure shows the preference trends, again, over the 3 cycles, and then overall on the far right. Overall, 68.5% of candidates preferred virtual, while 31.5% preferred in-person. This table represents the breakdown of candidate characteristics by interview format preference. It's a busy table. We tried to highlight the main findings in red, but I will draw your attention to the following. Although not statistically significant, there was a higher proportion of females who preferred virtual. There was no difference based on minority status. Applicants who signaled the program were more likely to prefer the in-person format. Applicants from more distant geographic regions, and in this case that would be non-Midwest regions, were more likely to prefer virtual. And at the bottom right, you can also see that the median distance in miles between an applicant's medical school and our location was significantly greater in those preferring the virtual format. Applicants with IMG status were more likely to prefer in-person interviews. There was no difference when comparing osteopathic versus US allopathic, and preference trends were similar over the interview cycles as well as amongst the ranked quartiles. And lastly, those who preferred virtual format had a higher USMLE Step 2 score overall. Here we present the results of a multivariable logistic regression of factors associated with the likelihood for interview preference in the form of a forest plot. So on the left of the line, we can see factors associated with the lower likelihood of virtual interview preference. So applicants who signaled the program and international medical graduates were far less likely to prefer the virtual format. Stated alternately, applicants who signaled the program were 2.85 times more likely to prefer in-person, and IMGs were 4.76 times more likely to prefer in-person. And then on the right of the graph here, we see factors that are associated with a higher likelihood of virtual preference, and those were applicants with higher USMLE Step 2 scores and those from more distant schools. This table shows the results of a subgroup analysis that we performed comparing those who signaled versus those who did not signal the program. We conducted this just because we had suspected that program signaling may play a role in applicants who are perhaps less traditional. And again, the group who signaled were far more likely to prefer the in-person format. We also found that applicants who signaled the program were more likely to be male, have an osteopathic degree, and be an international medical graduate. Limitations of this study are those that are common to a single institution analysis, small sample size. We excluded the applicants who had no preference or stated no preference. And then additionally, there were certainly unmeasured variables that we didn't account for here, but particularly financial resources probably played a pretty large role in an applicant's choice. So the results, I think the results challenge the belief that the hybrid model contributes to inequity. There's nearly 1/3 of applicants prefer the in-person format. There's clearly still demand for that format. And we observed that international medical graduate and signaling applicants were more likely to prefer the in-person format. Although there was not initially a preference of osteopathic graduates for the in-person format, they were more likely to signal the program. We feel, therefore, it is reasonable to assume that less traditional applicants view the in-person format as an opportunity to improve their chances of matching, and we therefore advocate for the continued use of a hybrid format in surgery residency moving forward despite AAMC recommendations. Thank you.
Thank you. I did forget to mention that this is a candidate for Best Paper by a Surgeon in Training Award. Invited discussant is Dr. Richard Anderson from the University of Illinois at Peoria.
Thank you. Deciding whether to do a virtual versus an in-person interview was a very hot topic at this year's Surgical Education Week for the program directors. The authors here today from Western Michigan proposed a hybrid approach, allowing candidates to select their preference. After reviewing the manuscript and listening to the presentation, I have 4 questions for you. Do you at your institution have a preference, and why? Does your program signaling play any part in your program, and how do you use signaling in your program? Do you feel there's any bias in your ranking based upon whether it was a in-person versus a virtual interview? And finally, are you going to continue your hybrid approach? I'd like to thank the Midwest Surgical Association for the opportunity to discuss this paper. I'd also like to thank the authors for allowing me to review their manuscript and getting me the manuscript well in advance of the meeting. And I look forward to this in final print. Thank you.
Thank you. So to answer your first question, we prefer the hybrid format, and it primarily based off the fact that you give the applicants the choice and they can pick what they prefer. In terms of the role of signaling for our program, the short answer is yes, but it doesn't guarantee an interview. The numbers I have from last year, from the last cycle, we had 960 applicants. 147 of them signaled and 23 were interviewed. So about 16%. It doesn't, sway it too much. In terms of the ranking, if there's any bias based off of what they ended up doing virtual or in person, based off of our data, at least when breaking down the applicants by rank quartile, there was no difference in preference. So at least at our program, the interview format did not influence the ranking process. And lastly, yes, I think we would continue to advocate for the use of a hybrid format. We currently do 6 total, with 2 of them being in person, and we've adjusted that as needed based off of applicants' preferences.
Thank you.
Thank you.
Mark Hill, Chicago. Last year at Mackinac, there was a great paper with great interest, and I cannot recall who who presented it, of medical school applicants using AI to do their essay. And actually the presenter did an AI generated essay right during the presentation, and the institution changed to no longer accept those essays. And in listening to you now, do you think that the trend in the future will be to making in-person interviews the standard as it was years ago?
I think there is quite a lot that has changed since COVID, and I think that getting people to buy into going back to a fully in-person format is, I don't see it happening. But I'm just speaking from the perspective of one institution, so I can't really speak to it. I think having both options available is probably the best way to go about it, because there are people who value that in-person experience. But I think to fully go over, I could not see that happening.
Thank you.
Matt Chung from Grand Rapids. When the signaling was limited to 5 programs, I agree. I didn't look at that. But when they expanded to 15, and I'm not one of your 15, I don't know about the rest of the, I don't want you unless your, step 2 score is 300. So how do you guys get on? I mean, I just don't believe you when you say it doesn't matter at all. I may have missed this. So of the people who signaled and not signaled and came to interviews, and then the people that were there in person compared to virtual, what were the match rate, I guess, amongst the 2 groups?
Yeah, I don't actually, and that's a wonderful question. All I know is that from last year so there was 960, because I guess we were looking at the signaling and playing in a role and getting the interview in the first place, but looking at the match rate would have been certainly useful. What I can say is the data that I have, at least, is that it didn't affect rank quartiles from our standpoint. So we did not rank anyone differently based off of whether they did an interview in person or virtual. It would be interesting to see what that looked like in terms of signaling, because we didn't evaluate that, but that is certainly something. And you're right, when now you have 15, I mean, the whole game's changed a little bit, and now it has much more weight, because like you said, if you're not getting signaled and you have 15 choices, that certainly means something more than if you only had 5. So.
Katrina from Indianapolis. Having just finished fellowship interviews, using the hybrid model, I found that I tended to rank in-person programs higher than my virtual ones. Is that something you are able to look at or have found with your applicants?
We didn't look at that necessarily, but I can certainly see that. And I think that plays into why we feel it's important. And it's because we found, at least from our experience, that less traditional applicants, like international medical graduates and osteopathic graduates, tend to prefer the in-person format. And I think that they see that as a valuable way to improve their chances of matching in relation to a standard US allopathic graduate. Whether that's necessarily true, I don't know, because we didn't look at that. But I think that the reason for having the in-person is exactly what you described there.
Thank you.
I feel like I have a dumb question and a dumb comment to make, so I apologize, but like, I just can't imagine, my question was, with the residents that you have in the last couple of years, I mean, has anybody actually come to the place without seeing the place? I mean, I just can't imagine doing that, moving to a place for 5 years where I'm gonna be stuck with you guys and not actually having physically been there to look at it first. The comment that I wanted to make is, I feel like AI is writing the essays. The robots are going to do the operations. Nobody's going to know where the transistor was invented, which is at Bell Labs in New Jersey. We're humans. This is a human profession. We're taking care of patients who are parents and children and brothers and sisters. the comment, which sounds dumb to me, is let's keep the humanity in the profession. I would like to see you before you become part of the team. I think there's some value to that. But the question was, do you know? Are the residents coming without actually physically seeing the building before they get there? And how do they like it?
The answer is yes. And you know, it is kind of astonishing, but yes, no, the answer is yes, I don't know exactly how many, but there's definitely residents coming in their first day, you know, stepping foot in that hospital is the first time they've been in Kalamazoo, Michigan, essentially. Which is crazy, but
But I will tell you, as somebody from Chicago, the zoo is amazing. Like, it's a great place to go.
But no, it's very interesting. The zoo. It's good. All right. Thank you.
Thank you. We'll move on to the next paper.
All right, the next paper for presentation is entitled Semi-Urgent Non-Obstructed Gastric Volvulus. Are outcomes equivocal to definitive repair in the early elective setting versus repair during the index hospitalization? This is from Dr. Lakova and colleagues from Corewell Health West in Grand Rapids, Michigan.
Thanks, Dr. Wright, for the great introduction. Good morning, everybody. Gastric volvulus. Gastric volvulus was first described in 1886 by Antonio Barudi. He noticed it during a female autopsy. It's described as the rotation of the stomach greater than 180 degrees around either a longitudinal or transverse axis, as you can see in pictures A and B. Typically, patients present with epigastric pain, retching, abdominal distension, and historically, gastric volvulus was considered to be a surgical emergency, with morbidity and mortality as high as 30 to 50%. In 2016, Light et al. Described a new clinical pathway or algorithm to triage these patients. If there was clinical suspicion, they would undergo a CT abdomen or chest, abdomen, pelvis. If there was signs of hemodynamic instability or gastric ischemia or perforation, they would undergo emergent surgical intervention. If the patient was hemodynamically stable with a well-perfused gastric wall, they would be placed in the non-operative management group with NG tube decompression with hopes of resolve. At the end of this paper, the author recommended that outpatient operative repair would be more beneficial, with the assumption that it would yield higher outcomes for these patients. However, within current literature, there is a gap regarding the appropriate timing of this specific patient population that undergoes outpatient repair. In our institution, we have a very similar algorithm. The patients who undergo non-operative management are decompressed for 24 hours. They then undergo an upper GI series where we evaluate, did they resolve this obstruction or did they not? If they continue to have an obstruction, they undergo surgical intervention. If they have resolution of their symptoms, then it becomes a discussion between surgeon preference and the patient, whether they undergo repair at the index hospitalization or as an outpatient, with our goal being the outpatient repair happens within a 2-week time frame. So the objective of this study was to evaluate our institution's outcomes related to repair during the index hospitalization versus urgent elective repair using the Clavien-Dindo classification system. Our hypothesis is that outpatient repair will result in better outcomes. This was a retrospective cohort study with patients undergoing repair from 2017 to 2022. Our exclusion criteria included the inability inability to radiographically resolve your obstruction initially, so after that upper GI, and then obviously patients who underwent surgical intervention emergently. 25 patients met our criteria. They all underwent our institution's algorithm, and 10 patients had their hiatal hernia repaired during the index hospitalization, and 15 underwent outpatient repair, again, with the goal of having this repair done within 2 weeks. Our primary outcome was morbidity using the Clavien-Dindo classification. Secondary outcomes are as listed, with specific importance looking at length of stay, time to surgery, length of surgery, leak or perforation, and revolvulus. Table 1 here describes our population by repair timing. Most importantly, you can see that there's no statistically significant difference between their age and their BMI. The median age of our patients were 78 years old. Table 2 looks at surgical intervention by repair timing. Here, our statistically significant data included time to surgery. You can see that on average, it took 32 days for those patients to have repair in the outpatient setting as compared to 2.5 in the inpatient setting. Obviously, we expected this difference. Another statistically significant finding was that the postoperative length of stay was 2.5 days as compared to 1.5 in the outpatient setting. Results that were not statistically significant, but we thought were clinically significant included length of surgery. Overall, 32 minutes. Inpatient operation was 32 minutes longer than the outpatient setting. And then very importantly, three of the patients in the outpatient repair group underwent revalvulization, and one of those patients actually had it multiple times. Table 3 summarizes the clavio-dendo complications by repair timing. As you can see, there was no statistical significance or difference in the morbidity between inpatient and outpatient cohorts. There were no grade 4 or 5 complications. 2 patients experienced postoperative pneumonia in the outpatient group. 1 patient in each group returned to the operating room, and there was 1 instance of a contained leak in the inpatient cohort. So as demonstrated by our data, the time to operative intervention in the outpatient setting is much longer than our intended 2 weeks. On average, it was 52 days or 7.5 weeks. Specifically in this patient population, it brings up some concern of this current algorithm. Reasons for delay include the elderly population oftentimes has cognitive delay. They may have difficulty with follow-up. They may have financial concerns of insurance coverage. They often lack support with transportation and lack of support at home or in an institution that they live. Long wait times to see consultants. As a lot of you know, it's difficult to schedule patients within a 2-week time frame when you have a busy practice. And then there's high dangers in this delay. There's high rates of recurrence. Sue et al. Quoted that 64% of patients who didn't have operative intervention recurred with a gastric volvulus after their first resolved episode. As you can see, 3 of our patients had that, with 1 having multiple recurrences. This increases hospitalization, it increases strain on our healthcare system, and there's a possible increase in morbidity and mortality if their recurrence requires emergent operative intervention. Overall, there was a slightly longer operative time in the inpatient cohort by 32 minutes. This is likely due to the acute inflammatory state. Dissection may be harder, the tissues may be more friable, and this may be of significance for patients where general anesthetic is very dangerous to them. Prolonged postoperative length of stay. Typically, this is due to disposition issues for elderly patients, which we all know and deal with on a daily basis. However, despite all of these findings, there is no increase in morbidity and mortality if they're repaired during the index hospitalization. Some of our limitations, obviously, a small sample size with limited power to find any statistical significance, even if it exists. Some of this is, we think, likely due to the limitation of using the search engine, and our inclusion criteria may have been quite too small in terms of our CPT codes, because we know our volume is much higher than that. And then with any retrospective study, surgical clinical judgment and experience is not portrayed because we can't control for that. So I think depending on who's on call, who sees those patients, the outcomes may vary. So in conclusion, currently, we assume that outcomes would be superior in the outpatient repair group. However, our study demonstrates that definitive repair can safely be performed during the index hospitalization without any statistically significant increase in morbidity. We suggest that offering surgical repair at the index hospitalization may benefit this patient population specifically due to the previously discussed limitations in their healthcare. Obviously, shared decision-making between the patient and their surgeon would likely yield the best outcomes. However, I think this may be a good start. And further research that adjusts for our limitations would be prudent to prove these results. Thank you.
I should also note this paper is a candidate for Best Paper by a Surgeon in Training Award. So we'll now open discussion with Dr. Hawassli from Henry Ford St. John Hospital.
I would like to congratulate the author on a topic that's very timely and thoughtful and clinically relevant study. It addresses an important gap in the literature regarding the optimal timing of hiatal hernia repair after resolved gastric volvulus, particularly in an elderly population. While the study suggests that index hospitalization repair is safe and potentially preferable, the small size sample limits definitive ready conclusion. Additionally, the observation of revolvulus in the outpatient group highlights the practical risk of delayed repair, especially in patients with poor follow-up reliability. That's been said, the retrospective nature and selection bias really warrants caution in applying this universally. I'm going to ask you comments one by one so you can answer timely. You did not comment on the type of surgical procedure was performed. Was there only a crural repair with reduction of the volvulus? Was there any anti-reflux procedure performed in addition to that? And was there any gastropexy performed as well? In between these two groups, is there difference?
Yeah, thank you for the question and your comments. I can go back. Oh, maybe I can't. Go back to the slide in table 2. It does describe how many patients received cruroplasties, gastropexies, and fundoplications. The difference laid in the outpatient setting, only one patient did not receive a cruroplasty. They received a gastropexy. Thank you. They received gastropexy only. In the inpatient group, 3 patients did not receive cruroplasty. 2 of those patients received gastropexy only, and 1 of them received fundoplication only.
Because that adds to your operative procedure timing if you're just doing a reduction and gastropexy without doing a crural repairs. The second comment is on your length of stay. It's not fair to say there is no significant difference when you have a time to study the patients and keep them in the hospital 2 or 3 days, where the other ones are coming in electively. Have you added the time of these first patients, of the group who went home? Have you added the time that they spend in the first index and added to their time of the second procedure?
Yeah, I do want to clarify that length of stay is post-operatively. So it doesn't include the time that they were admitted and having, the NG decompression and upper GI. So the 2.5 days was after they had operative repair. But that would be very interesting to look at. I didn't personally, but yes, for specifically the outpatient group to calculate how many days were they in the hospital on the index admission, and then post-operative length of stay was 1 day for our outpatient cohort. However, that actually translates to discharging on post-op day 0, which would just be post-operatively. But to kind of add that time and compare it to the inpatient group. But those numbers and days is just post-operatively.
So were there any clinical or social factors that tended to guide the surgeons toward index versus outpatient repair other than comfort and experience? And how might this have affected your selection bias?
Yeah, definitely. I think that's part of one of the huge limitations of retrospective studies is our group that deals with foregut pathology covers a very large, pretty much the whole west side of Michigan, a very large encompassing area. And so we have a lot of patients who get transferred from outside facilities from far away. And I think that that shared decision-making, if patients live, 2, 3 hours away, it's going to be very difficult for them to come back, follow up in the outpatient setting, have a office appointment, and then be scheduled for surgery. That can be very difficult for them. And so I think that does push some of our surgeons to say, okay, your healthcare, your other comorbidities are stable at this point, and there's no really other optimization that we can do. And so repairing or doing this for you at the index hospitalization would benefit you greatly.
I mean, having said that, I mean, the sample size is very small, and how reliable are you thinking that the mortality and morbidity will be the same, having given the factor that you're this low power study?
Yeah, it's very unfortunate that it was so low power. Currently in the works on working on that and working through a better search engine. Of course, I can't extrapolate this to everybody, and I can't extrapolate these results and say everyone should get index repair.
So have you changed your practice in your hospital? Have you adapted that now everybody has to have the index hospitalization to have a repair their valvulus, or are you still doing the same thing? Every surgeon does what he wants.
Yeah, we're currently doing sort of the similar, a similar thing. We were talking about it with the group, and I think some of this data and just their experience would show them that the patients we repair at index hospitalization do well. And so that maybe gives us confidence that that may be the right thing to do, and gives them kind of that push because they've had that experience.
Do you think multi-center studies may be recommended from your paper to see if this is really validated for the future?
Yes, I think that would be a great idea.
Thank you.
Thank
Appreciate it.
you.
We have time for one more question.
Larry McKay, West Michigan. So I'm just curious, to me, at our center, I have seen a few gastric volvuluses, and, I did upper GI lap Nissens like 30 years ago when I was in the Navy, and have not done them since. So what we try to do is similar, if it's not necrotic stomach or the patient's not tanking, our goal is to switch the care to someone who does upper GI surgery for a living. So I don't know if you've looked at that, but to me, that's the better model, not how soon, now or 3 weeks from now, but, someone who's prepared to do perforated colons, appies, gallbladders, the typical things come in. But this is kind of a tweener. It's like it can be that we all need to take the patient to the operating room that night. But I think we're finding maybe 85, 90% can be managed more electively. And I would suggest that you need to look at how many patients transfer to an experienced, a foregut surgeon.
Yeah, thank you for your question. And I do think because a lot of, we have patients who come directly from the ER. However, we did include all of the patients that were a direct admission from a transfer from an outside facility for your exact reason. Yes. Yep. Sorry. Yep. The group is a combination of MIS, bariatrics, and general surgeons who all perform these surgeries on a daily elective basis. And so it would be very interesting to look at how many patients were transfers and how many patients were direct admissions from the emergency department, and kind of compare what was that time that they had at the other hospital and what does that look like? Because yes, obviously, if you're a colorectal surgeon taking general surgery call, you're probably not going to do a chorioplasty and a fundoplication electively. And so I do think sometimes transferring or doing it as an elective practice is just best for the patient because they can be in more experienced hands.
All right, thank you.
Thank you so much.
Next paper is also up for Best Paper by a Surgeon in Training Award. Dr. Katrina Theed, delays in length of stay. Why are patients not being discharged with Ascension St. Vincent, Indianapolis?
Hello, good morning. I will be presenting increased length of stay. Why are patients not being discharged out of Ascension St. Vincent Hospital in Indianapolis? I have no disclosures. So in 2022, the American Hospital Association put out a report that found that Hospital length of stays had increased 9.9% compared to pre-pandemic levels. While the AHA associated this with increase in patient acuity, we felt that anecdotally, delays in discharges were contributing to this increase. A discharge delay is when a patient remains in the hospital despite medical clearance, and this is important because it's been associated with increased morbidity, mortality, and cost. Our goal was to evaluate the rate and reasons for discharge delay in relation to discharge location for trauma patients at a community level 1 trauma center. Our hypothesis was that discharging to a post-hospital care facility would result in a more likely chance of a discharge delay. To perform a study, we did a retrospective review of all major traumas from January 1st, 2021 to December 31st, 2021. We excluded all patients who died in the hospital, left AMA, or were discharged from the ED without admission. We collected data from our trauma registry and manual chart review, including date of discharge and discharge location, the date of medical clearance, and then reasons for delay based on case management documentation and total charges for the admission. We then calculated odds ratios for discharge delay based on location, and then our excess charges were estimated by dividing the total charges by the patient's length of stay, and then multiplying it by the days delayed for each patient. We included 295 patients in our study. 131 of them required ICU care. Overall, we had a 37% discharge delay rate. That number was higher in the ICU patients at 53%, and our non-ICU patients only experienced about 25% discharge delay. Our average length of stay was 8 days, and our average days delayed was 3.8 days. In total, our estimated total excess charges was about a little over $1 million. In looking at our results further based on discharge location, we found that going to jail actually resulted in no delays to discharge. But our highest delay rate was in our acute rehab and SNF population, which was 87% and 65%. The odds ratios for discharging to post-hospital post-hospital facilities were all increased, so increased risk of delay, and those facilities included psychiatric facilities, LTACs, acute rehab, and SNFs. Our confidence intervals demonstrate that the discharges to acute rehab and SNFs were significant in their delays. When looking at reasons for delays, our top reasons were bed availability, prior authorization and pre-certification, and awaiting referrals and acceptances. We also noted that 10 out of the 18 reasons for delay required some sort of case management assistance, including our top 3, and then other causes such as transportation, workers' compensation, and charity care. In looking at our results, our study supports the hypothesis that patients discharging to a post-hospital care facility have a higher likelihood of experiencing a discharge delay. Facility referrals and insurance approval are major barriers to discharge, though the bed availability may point to a local deficit in some of these facilities. In addition, our data shows that case managers are critical in coordinating efforts to discharging our patients, especially when they're going on to further care. Some limitations to our study include the fact that it's a single center retrospective study. We did not evaluate the complications due to discharge delays, and our excess charges may be overestimated since trauma patients require more resources at the beginning of their hospital stay compared to their end. In conclusion, increased efforts should be put towards early coordination with case managers when discharging patients to post-hospital care facilities. Thank you.
Thank you. And our invited discussant is Dr. Vivian Gatan from Loyola University Medical Center.
Congratulations on the study. And I'd like to thank Dr. Thied for sharing the manuscript well in advance. Delay in discharge is an important area to increase throughput of our patients and decrease unnecessary costs, and with the consideration, obviously, of profitability and now more than ever viability of our medical centers. I have several questions. Do demographics such as age or sex or other factors that you could identify in that realm affect delay to discharge? You had spoken about this, about a limitation. Might there be other ways that you could calculate cost that would be more accurate? 2021 is sort of a tender time, right? We still had Omicron happening, at least in the first third of 2021 or so. And there were problems with not enough nursing, beds closed in many hospitals. Was this the best calendar year to see what's representative? Would it have any value to comparing it to pre-COVID times or even current times, which are further away from that? Has this analysis been reviewed at your hospital with administrative leadership? And do you have any strategic changes in mind to create improvements now that you've identified this? And finally, in the manuscript, you mentioned the importance of case management, which I think we all agree on. But I guess I was a little curious about weaknesses that you've identified. For example, specific points for improvement that are not just the number of case managers, is something such as service-specific case managers versus floor case managers, or some realm that you've identified would be more ideal. Thank you.
Thank you so much. So while we didn't run the demographic data to compare if this was effective or not, we did have injury severity scores. And it was, for the most part, if they had to go to a facility, they had a higher injury severity score. Our calculations could, for sure, have a better way of doing that. Unfortunately, with how the data came to us, it was just total charges for the admission. So I had no way of parsing out like when those charges were made. And then I do think there is value in getting another data set to compare. 2021, again, kind of coming out, I think it points to some of the stressors that our health system has when we have higher demands on care or for care. So further study could be done for those comparisons. And then this data has not been reviewed by our hospital yet. Some weaknesses, I think, for our case managers, the way our documentation system is, the case managers have to access a lot of systems, different systems. I think our nursing officer said they have to access like 8 or 9 systems to do any documentation and communication. So trying to lessen the amount of places they need to access. And then I know during COVID, they were handling 40 cases per case manager. So I think that number is less now. Pre-COVID, they were in the like 20 to 30 range. And I think we're back to that level.
Do you want to go first?
You're taller, go ahead.
Thanks for the interesting presentation. I think anybody who's worked in trauma feels this in their bones. They know this is a problem. Couple of questions I had for you was, when you looked at this data, did you look at time to first consultation for your care coordination? What is your habits of your hospital for your introduction of the care coordination service for this? Our habit was, as soon as a trauma patient came in and we knew they weren't going to die, they got a care coordination consult. But I don't feel like that changed anything at all at our hospital system. So my follow-up question was, are you guys going to do a multivariate logistic regression or something similar to look at things like insurance status, type of injury, location of where they come from, zip code wise, to see if there are other outstanding factors here that are limiting your patient's discharge capabilities? Thank you.
So for our ICU patients, we do have dedicated case managers for the ICU. So they get evaluated daily. But our floor patients, it's kind of hit or miss. Sometimes the case managers will look into the case. Other times they won't on their own. So there is some consistencies that we could put into our system for that. And then for the linear regression, that it could be further work done for the future for sure.
Mark Hill, Chicago. In one of my hospitals, even though the logistics seem to have been sorted out, if the discharge time seems to approach 5 o'clock or later on a Friday. And the weekend, the process seems to just stop. Is that just anecdotal to my hospital, or do you see that the time and day contributes to the delay in the transfer?
So while our data we didn't look at day of the week for discharges. Anecdotally, I feel the same way you do. But I did find a study in writing the manuscript where they had dedicated case managers for, I think it was a trauma or it was a medicine service. And they found that discharges on Friday, when there's dedicated case management, actually happen more frequently. So definitely, I think time of week is an important factor.
Thank you. Thank you.
Thank you.
Thank you.
The next paper is entitled Factors Influencing Resolution of Diabetes Mellitus in Bariatric Patients at an Urban Safety Net Hospital. Paper will be presented by student Dr. Horan from Metro Health Medical Center.
Thank you to the Midwest Surgical Association for inviting me to speak today. As mentioned, I'm a third-year medical student at Case Western Reserve University School of Medicine in Cleveland, Ohio, and I'm presenting my research conducted at Metro Health. I have no disclosures. The efficacy of bariatric surgery has been well established, both in promoting weight loss and resolution of obesity-related comorbidities, including sleep apnea, hypertension, gastroesophageal reflux, and type 2 diabetes. However, bariatric surgery remains underutilized, with an estimated only 1% of eligible patients undergoing this procedure. Additionally, the majority of these patients who do have the procedures are white, have higher incomes, and are on private insurance. This means that the benefits of bariatric surgery are largely not seen by the marginalized communities most impacted by obesity and its comorbidities. From the literature, we know that bariatric outcomes vary based on preoperative factors such as race and insurance status, as well as the type of surgery performed. Additionally, recent investigation of healthcare engagement has found that more healthcare engagement prior to surgery is associated with better weight loss outcomes. The establishment of bariatric programs at safety net hospitals is an important step in increasing access to this intervention. And studies exploring outcomes within these institutions have found promising outcomes, but some potential limitations as well. Additionally, data on how these established mediating factors influence outcomes within this unique safety net setting remain limited. Our goal was to explore the impact of race, insurance status, and healthcare engagement on bariatric outcomes within our safety net hospital, and specifically to see whether these factors influence the resolution of diabetes following bariatric surgery. To do this, we conducted a retrospective review with a representative cohort of patients undergoing primary bariatric surgery at Metro Health between 2019 and 2024, and who had a preoperative diagnosis of diabetes. We first identified all bariatric patients from the years 2019 to 2024 using the Epic self-service reporting tool Slicer Dicer. From this larger group, we identified a random cohort for analysis, for an interim analysis. We then identified in this group patients who had a preoperative diagnosis of diabetes, which we defined as hemoglobin A1C greater than or equal to 6.5 recorded in the year prior to surgery. Data was collected via chart review and included demographic factors, type of surgery, and our measure for healthcare engagement, which was visit with a primary care provider in the year prior to surgery. We also collected data on our outcomes of interest, which included weight prior to surgery and at 1-year follow-up, mortality and readmission within 30 days, and hemoglobin A1C. We defined postoperative resolution of diabetes as a hemoglobin A1C less than 6.5 within 2 years of date of operation. We then compared rates of resolution of diabetes within 2 years postoperatively based on race, insurance status, type of surgery, and recent PCP visit using bivariate analysis with chi-square tests, as well as logistic regression models to generate odds ratios. From our initial query of all bariatric patients in our time frame, we identified 1,320 patients. We then generated a random cohort of 328 patients for an interim analysis. Of these patients, 114 met our criteria for preoperative diabetes diagnosis. And then within 2 years postoperatively, 61 patients or 53.5% had resolution of diabetes, while 53% of 53 patients demonstrated persistent diabetes. Subgroup analysis by race and insurance status did not find any statistically significant differences in outcomes, including percent total body weight loss, readmission, mortality, or our main outcome of interest, resolution of diabetes. Notably, our cohort demographics were 54% Black and 56% of our patients had Medicare, Medicaid, or no insurance, which is in pretty distinct contrast from the typical population captured in bariatric literature. When we looked at procedure type, we found no difference in percent total body weight loss, readmission, or mortality. But interestingly, we did find that those undergoing sleeve gastrectomy were actually 4 times more likely to have resolution of their type 2 diabetes compared to those undergoing Roux-en-Y. And then finally, while we found no difference in weight loss or readmission, we did find that those with a recent primary care visit were more likely to have resolution of their diabetes than those without that recent visit. Mortality was also significantly different, with 1% mortality in those with a recent visit compared to 11% in those without. As an interim analysis of a larger bariatric population, we do have some notable limitations to these findings, including confounding factors and limited power. Additionally, by defining diabetes diagnosis and resolution only by hemoglobin A1C, without considering things like disease duration, insulin requirements, or medication use, we may have overestimated rates of resolution of diabetes, and we also may have lost some of the nuances in the impact of preoperative disease severity in odds of resolution of diabetes. Future studies can explore the role of surgeon decision-making on type of surgery performed, as well as the impact of preoperative diabetes disease severity. And then finally, an ultimate goal of implementing and evaluating interventions to promote healthcare engagement and measure for improvement in outcomes. So in conclusion, we found race and insurance status were not predictive of diabetes resolution within our safety net hospital bariatric population, but that type of operation and healthcare engagement were. In contrasting to the existing literature, we found increased resolution in those undergoing a sleeve gastrectomy compared to Roux-en-Y, which we think could reflect some amount of selection bias in surgeon decision-making that can be better explored with future studies. And then finally, we found the association between greater healthcare engagement and better rates of resolution, even in the absence of improved weight loss, which could suggest healthcare engagement as a possible area for intervention to promote postoperative glycemic control. Thank you, and I'm eager for any questions you might have.
No pressure, Sarah, but the invited discussant for your paper is President of the Midwest Surgical Association, Dr. Peter Hollowell.
No pressure. I congratulate you on investigating the largest and most under-recognized disease we currently face, and an excellent presentation today. Obesity underpins most of the other issues we deal with in modern healthcare today: cancer, cardiovascular disease, diabetes, hernia, and many more. The story of obesity has weaved through our meeting with the disease of obesity likely related to dysregulation of GI hormones, in particular GLP-1 being the most likely candidate. Dr. Ellison on Sunday night talked about the initial discovery of the GI hormone gastrin and how that's exploded over the last 70 to 80 years. Dr. McCahill talked about a difficulty in palpating clinically significant nodes in obese patients undergoing cancer surgery, Dr. Ganem's presentation on treating obesity, and Dr. Shermer's cost of medical care in the age of GLP-1s costing up to $1,000 a month to treat this disease. Metro Health serves a population of patients that are under severe stress for social determinants of health. Data in this population is highly valuable. I have 3 questions for you, and I'll have you answer them each separately. As you noted in the introduction, gastric bypass tends to produce better diabetes resolution. Randomized controlled trials show no statistic differences between sleeve or gastric bypass. However, this study shows the exact opposite. Can you explain some of the results?
We were also surprised by these findings based on the type of procedure performed, and I touched on this very briefly, but one of the major limitations, I think, of the study as we have it now is that we did not account for preoperative disease severity. And so I think one aspect that could be at play is some element of selection bias with surgeon decision-making, where patients who had worse preoperative disease were maybe preferentially offered Roux-en-Y, because there seems to be some data that there are better outcomes for Roux-en-Y. So without kind of having that data of preoperative disease severity, it's difficult to say if that's the case, but I do know that surgeon decision-making might play a role there.
Mortality in bariatric over the last decade has been driven down to way less than 0.5%. So it jumps off the page that you have 11% mortality in the patients who didn't see a PCP. Can you explain that?
So one aspect of another limitation is the small sample size. So we did only have 2 patients who had a mortality recorded in the 30 days after surgery. I was trying to go back and look at the data. We did not record cause of death if it wasn't related to surgery, so neither of these were necessarily surgical outcome related deaths. And then I was having some technical difficulties trying to get into their charts to understand this a little better. But I think, again, with such a small sample size, it's difficult to extrapolate what this could mean. But what we could be seeing is that this having a recent primary care visit is acting sort of as a proxy for formal linkage with healthcare systems, and that in and of itself is maybe protective against poor outcomes.
Using this data, how would you change practice going forward? For instance, would you require a PCP engagement before offering surgery, or would you bring PCP care into your group with, say, an APP?
I think when we're thinking about an intervention that's underutilized, and especially in this population that has historically had poor access, adding additional requirements for surgery would be a challenging decision to make. But I do think that building off of our existing framework for preoperative preparation, and we have teams of physician assistants and things like that who work with patients to prepare them and their families for surgery. So building on that existing framework would be a good next step. Additionally, one of the studies I referenced looking at healthcare engagement looked at healthcare engagement as measured through things like MyChart messaging. And so even kind of lower or less labor-intensive interventions, but just increasing interface with the healthcare system through virtually could be a simple and cost-effective, potentially, way to try to increase engagement and then measure if we can see some improved outcomes.
Great job. Thank you.
We just have time for one more question.
Yeah, Bruce Shermer, Charlottesville. Very nice paper. It's unusual to see that sleeve gastrectomy is more effective against diabetes than gastric bypass. And that's not been shown in most studies. And so I think you're correct. And it's very likely that surgeon decision to which operation to do may have been influenced by, if the patient had diabetes, then they got a gastric bypass. And the real question that you need to ask and go back and look at your data is how long and how bad was the diabetes in the patients that had gastric bypass? Because if they had long-standing diabetes, we know that gastric bypass is as effective as it is not as effective in patients who have long-standing disease. And so that probably had an influence on your data.
Thank you. I think that is a great point. I think, as I mentioned, not exploring that preoperative disease severity is a big limitation and something that we hope to correct moving forward as we expand to look at our entire cohort rather than just this sort of interim analysis. Thank you.
Thank you.
Our next presentation is Slipping from the Shoulders of Giants, a comparative bibliometric analysis of research trends in surgery, 1980 to 2020. David Bohannon from the University of South Florida.
Good morning. Today, we're presenting a bibliometric study describing the history and current status of surgical research. Bibliometric analysis, in simple terms, is a study of studies using publication data and evaluation of article features. These windows into the past are imperative in all disciplines to identify where changes can be made for field-wide improvement. With respect to our field of surgical research, evidence in the past couple decades has backed up anecdote, finding surgical research to have secured less funding, made weaker pipelines to research throughout medical training, and had less relative impact on the field as a whole when compared to medicine. To explore this further, our 40-year comparative analysis of surgical to medical research particularly looks at individual article metrics, which use citation analyses and prediction algorithms to give insight into the publication level impact of an article on its respective field. Additionally, we include other common bibliometrics accordingly to give context to whatever differences we found. Quick overview of the metrics that we used. First is relative citation ratio. This is an NIH-developed and well-validated measure of article impact that field and time normalizes articles compared to a benchmark set of other NIH-funded projects. It's increasingly been adopted by many as a quality measure of article influence or researcher scholarship. Secondly, we have field citation ratio. It's a similar metric proprietarily developed by Dimensions AI that also field normalizes through a different algorithm, albeit. I will note it has a bit less validation, though it has increasingly been adopted in certain research circles, again, as a measure of article influence. And finally, we have altmetric attention score, a bit different, also developed by Dimensions AI. This one measures non-academic sharing of scholarly work. Now, this is your news outlet shares, your social media posts, your blog posts, and things of that nature. To perform our analysis, we took 1,000 of the top cited papers in each decade between 1980 and 2020 in surgery, medicine, and we included biology as a non-medical comparison. We retrieved all the article metrics publicly for iSites on the NIH website, then through the Dimensions AI API for FCR and altmetric attention score. To date, we're not aware of another study comparing these disciplines at the scale with these metrics over this time period. After collecting data, we plotted the temporal relationships of the three metrics here, which clearly show a discrepancy between surgery and the other fields. You'll see medicine experience significant growth in RCR on the left and FCR in the middle, while surgery has remained stagnant or in some cases significantly decreased. Of course, additionally, beyond the trend of increases in medicine and stagnancy in surgery, the magnitude of the metrics is significantly different between the two fields, suggesting less relative impact in surgical research. Attention score on the right shows significant increases in all three disciplines, likely owing to the internet, globalization, and social media. Remember, we're looking back from 1980 here. Similarly, though, there's significant magnitude difference as well, indicating reduced public visualization of surgery when compared to medicine. Moving on to funding. In the graphs here, we show frequencies of NIH funding by the number of grants that an article received. And we have an other column for non-NIH sources as well, 1980 on the left and 2010 on the right, going forward in time. As probably expected, since the 80s, funding across the board has increased in all three disciplines, but where medicine and surgery really differ is the rate of funding increases, particularly ending up in the 2010s. Medicine has reached a point where only 11% of studies report no funding source, whereas 50% of the surgery sample reports no funding source. You'll see in that orange circle. Additionally, we see that medicine has secured a lot more non-NIH sources in recent years in that green box there. And interestingly, NIH funding for both medicine and surgery has experienced a dip from peak levels in the 1990s, and it has not returned to those levels since, at least in 1,000 top cited articles per decade. Other particular differences we wanted to highlight include journal distribution. Pie charts here show what proportion of those 1,000 studies in each decade are taken by the top 10 journals. And we include the other slice of the pie for anything outside the top 10. You'll see medicine clearly is dominated by the New England Journal of Medicine since the 1980s, sometimes comprising up to 60% of that 1,000 publication sample. Beyond New England Journal of Medicine, right there, that other category you'll see is outside of the top 10 is only comprised of maybe 10 to 15 other journals. This is a significant and stark contrast to medicine, to surgery, excuse me, where surgery, that slice of the pie of other is comprised of 70 or 80 different journals. And beyond that, there's no clear dominant journal in surgical research. This may suggest that some sort of journal oligopoly, similar to medicine, where 20 to 25 journals that have the top cited articles may facilitate the environment for increased visualization and that increased impact as researchers both seek to publish and seek to consume research in these top, that small circle of journals. Other bibliometrics we wanted to highlight also include keyword and topic diversity. To do so, we took the keywords from each of those 1,000 articles in each decade and discipline and categorized them using the MetaMap software on the NIH website, which categorizes lists of keywords into the Unified Medical Language System Metathesaurus 127 categories. We then took the frequency of those categories and calculated the entropy metrics of them in order to describe the temporal trend of their distribution. Entropy metrics very quickly just describe how randomly distributed a sample of data is. In this case, we also found differences where surgery demonstrated increased concentration in select topics as the years went on from 1990 to 2020, whereas biology and medicine in this case both had increased subject diversity, showing up as similar trends in their entropy metrics across the 2 decades. So where biology and medicine increase in entropy, surgery goes down and vice versa. In interpreting our work, it's important to distinguish that these article metrics measure the relative magnitude of a breakthrough. This work is not saying surgery has not been making breakthroughs. Clearly it has. We interpret the data to say that the magnitude of these breakthroughs has not been increasing empirically, at least compared to medicine. To summarize, we note that surgery's relative impact in research has plateaued despite globalization and corresponding research growth efforts. Medicine and biology remain to have more diverse subject areas. The research is more collaborative and has been securing more funding across the past few decades. Going forward, surgery must evolve to increase broader scientific influence, improve pipelines to research through medical training programs, and increase collaboration to facilitate that environment where surgical breakthroughs improve patient care across the board. Thank you.
Invited discussant is Dr. Richard Berg.
I would like to thank the association for the opportunity to review the paper. Standing on the shoulders of giants is a famous, often repeated metaphor, which means using the understanding gained by major thinkers who have gone before us in order to make intellectual progress. This phrase is usually attributed to a 1675 letter written by Isaac Newton to his rival Robert Hooke, when he wrote, "If I have seen further, it is by standing on the shoulders of giants." Historically, I was able to find an earlier mention of this in 1159 by Bernard of Chartres, who compared us to dwarfs perched on the shoulders of giants. He pointed out that we see more and farther than our predecessors, not because we have keener vision or greater height, but because we are lifted up and borne aloft on their gigantic stature. I have a couple questions. I noticed that more MD, PhD graduates pursued medical fields than surgical. About 50 years plus ago, as a surgery resident, when I had aspirations of also getting a PhD, my wife told me to quit going to more school and just get a job. With the increasing length of time needed to become a surgeon, is an MD, PhD realistic or necessary anymore?
Thank you, Dr. Berg. I've also
One
seen.
more question.
Yes,
Do you
go
want me
ahead.
to do that at next, or?
You can go ahead with the second.
The last question, what can surgical researchers do to get their papers cited more or perhaps become more relevant?
Thank you for the questions. So reading into the literature about MD, PhD, just a bit, we have seen that as time goes on, like you're mentioning, less and less so those graduates are moving towards surgical research. Whether it's necessary, at least it looks like there have been more PIs from what I'm remembering in the literature, more surgical PIs, or more PIs in surgical research, not having the MD at all. They're just PhDs that are interested. Though necessary, we're yet to see. Again, like you mentioned, with increasing time of surgical residencies, it is harder and harder to find the time for research, but finding ways to make the incentive for once MD, PhD graduates have completed their training to pursue surgical research in some aspect, finding those incentives in the programs would likely help with increasing our impact and broadening the base of surgical research's foundation. As far as the second question, how to increase visualization, it looks like collaboration in medicine is, which I did not have in the PowerPoint, was much, much greater. The average number of institutions and authors per paper is much greater in medicine. There's more multi-institutional studies. And secondarily, I'll also point to the keywords and topic diversity that we mentioned. It seemed that medicine and biology, this is the biggest thing that they've done. And in some of the keyword clustering that we found is that medicine has sort of experienced this phenomena of biologization, where the keywords and topics in medicine articles tend to include more basic science terms with the increased use of personal medicine and molecular therapies, genetic therapies. We're getting down to including more basic science foundational concepts. Now, when you include those terms and topics in research papers, it broadens the audience and broadens the foundation of your citation network, just increasing the visualization. And by increasing audience, you can get more eyes looking at the papers, of course. Surgery has done this biologization, though less so and with only select topics. So maybe buying into that idea and looking more into focusing on personal medicine, genetic therapies, and research as well, which has been ongoing, but expanding that base even further, along with the collaboration that I mentioned, can help facilitate increased research impact in surgery. Thank you. Another
Yeah,
question?
Bruce
Yes.
Sherman from Charlottesville. 2 years ago, Dr. Natahari from our institution presented data from the American Surgical that looked at the success of graduates in surgery versus medicine in terms of obtaining grants after they finished their training, and it was much more, the medicine graduates far outshone the surgical graduates. You've probably seen the article. And thank you for presenting this data. This is a topic that we kind of have avoided in surgical training, and there's no question that we don't do it right. We have, in academic surgery programs, we have our residents do research in the middle of their residency. As a program director for 17 years, I can't tell you how many residents finished our program having done research in something that they didn't even go into. They changed their mind after finishing research and went into something completely different. We do research at the wrong time. We should be doing research at the end of residency and during or associated with fellowship. And that way, the people who really want to do academic surgery know what they want to do and will apply themselves and be funded in a way that will make sense. But the problem is, you can't. Changing that situation is difficult. When I was on the American Board of Surgery, I tried to get the board to consider this. The problem was everybody in the room had residents working in their lab, and they weren't going to vote for that. So it's an entrenched system, and it works to our disadvantage. It is not the right time to do research is when you're in the middle of your residency because you still don't know what you want to do. The time to do it is when you finish your training, and getting support for that monetarily by your employer is difficult. So we've got to come to grips with the situation if we're ever going to fix it.
Thank you for the comment. Yes, finding those incentives to increase or simply restructure the way research is done in surgical training is important. And Also, going back to that MD, PhD literature, finding ways to, again, incentivize graduates of those programs to really hone in on what they want throughout their surgical training and, again, find ways to restructure the programs that they will continue to do research after graduating both the MD, PhD program and throughout the residency, after the residence.
Thank you.
Thank you all.
The next paper, which is also a candidate for Best Paper by a Surgeon in Training Award, is entitled Resected Intrahepatic Cholangiocarcinoma: Is Adjuvant Chemotherapy Associated with Improved Overall Survival? It's presented by Dr. Wolanski from the University of South Florida.
Good morning. My name is Rachel Wolanski. I'm a fourth-year general surgery resident and current second-year research fellow at the University of South Florida. I do not have any disclosures. So intrahepatic cholangiocarcinoma, thankfully, is a rare but very lethal malignancy with poor overall survival. Recent randomized clinical trials evaluating the survival benefit of adjuvant chemotherapy have included heterogeneous populations with other cancers, including extrahepatic cholangiocarcinoma and gallbladder carcinoma, in addition to intrahepatic cholangiocarcinoma. And therefore, the overall survival of adjuvant chemotherapy in iCCA alone remains undefined. So our aim was to look and see if adjuvant chemotherapy confers a long-term overall survival benefit in patients with resected intrahepatic cholangiocarcinoma. And if so, what subpopulations may benefit most from the addition of adjuvant chemotherapy? We use the National Cancer Database Intrahepatic Bile Duct File for patients that were diagnosed between 2006 and 2017. We included adults with localized intrahepatic cholangiocarcinoma who underwent surgical resection. We excluded patients with missing data relevant to our study, anyone who underwent transplant, had multiple primary malignancies, or had distant metastasis at diagnosis. We defined adjuvant chemotherapy as beginning within 16 weeks of surgery, and patients were treated with adjuvant chemotherapy were 1-to-1 propensity score matched to patients who underwent resection alone. We controlled for confounders such as patient characteristics, including age, sex, race, their comorbidities via the Charlson-Deyo score, insurance, stage, adjuvant radiation, as well as resection margins. Kaplan-Meier methods were used to compare 5-year overall survival, and stratified Cox modeling was assessed to see the treatment effect of adjuvant chemotherapy. Here are some of our results of our cohort. Just looking, people who received adjuvant chemotherapy tended to be younger, female, have private insurance, have less comorbidities, and have advanced disease characteristics, including higher clinical stage, higher pathologic T tumors, as well as positive regional lymph nodes if regional dissection was performed, as well as increased size of tumors and positive margins. They also received adjuvant radiation at a higher rate than people who did not receive adjuvant chemotherapy. Here are some factors associated with overall survival on pre-matching, so before propensity score matching. On survival, you can see patients that were older, were male, had more comorbidities, and again, advanced diseases had worse overall survival. At the bottom, you can see I included adjuvant chemotherapy while the hazard ratio was less than 1, indicating potentially a survival benefit. It was not statistically significant, even on pre-matching analysis. Here we move on to our Kaplan-Meier analysis of our matched cohorts. So we had 377 pairs of patients in our overall cohort, and they did not have a statistically significant overall survival benefit when treated with adjuvant chemotherapy. Included the median survival analysis on the right-hand side, and although it trended towards longer with addition of adjuvant chemotherapy, this needs to be interpreted with caution given the insignificant p-value. So we can't say either way whether this was longer or shorter because of the statistical insignificance. From here, we broke it down to further subgroup analysis. These patients had pathologic T3 or T4 tumors. There were 114 matched pairs, and again, there was no statistical significance on Kaplan-Meier, as well as with the median survival benefit. The next subgroup was the patients who were margin positive. Again, non-significant p-value, although the trends may be trending towards significance, and we may be limited by power here. Our matched pairs were 66. And again, insignificant both in Kaplan-Meier and in the median survival analysis. This is our last subgroup, node positive patients. Again, no significant difference was found in this group either with the addition of adjuvant chemotherapy. So in summary, patients in our cohort that received adjuvant chemotherapy tended to be younger, female, have private insurance, and fewer comorbidities and advanced disease, higher stage positive lymph nodes, larger tumors, and positive margins. There was no overall survival difference in our propensity matched cohorts, even on subgroup analysis. And the margin positive cohort trended towards significant difference, but it may be limited due to lack of power in this further subgroup analysis. Our study does have limitations. First off, being a retrospective database review inherently comes by limiting the granularity of data that we have available to us, including chemotherapy regimens and doses of the patients received. We also have limited data on their specific comorbidities and nutritional performance status that may affect their overall survival. We also do not have information regarding disease recurrence, disease-free survival, or specific cause of mortality. So those were assumptions made. So in conclusion, our study found that adjuvant chemotherapy does not provide a long-term overall survival benefit. Although we had a trend towards longer median survival with adjuvant chemotherapy, this was not statistically significant and must be interpreted with caution. This highlights the critical need for intrahepatic cholangio-specific prospective trials with novel therapeutics to continue to combat this rare but very lethal malignancy. I'll take any questions.
The invited discussant for this paper is Dr. McCahill from Western Michigan University.
First of all, thank you, Dr. Wolanski, for getting me your manuscript on time, and it was a great read, and I definitely found it extremely interesting and encourage the Midwest Surgical members to take a look at it. Dr. Wolanski and colleagues performed a really elegant propensity score match study using the NCDB, a database where I think it is much richer in important cancer outcomes that cancer surgeons like to look at, such as cancer differentiation, nodal status, tumor size, and R0 status. So many other databases are missing this. The premises of this study seems to be that prior randomized controlled trials, there were two of them that you mentioned, did not get the answer quite right. So I did review those two studies, and they were quite notable in their extent and level of participation. I'll try and summarize them very quickly and then get to your questions. So Protege 12 was conducted over 6 years, and it looked at GEMOX utilization within 3 months after resection of biliary tract cancers. And that seems to be the thing that you're taking issue with, meaning intrahepatic cholangiocarcinomas, extrahepatic, and gallbladder cancer. And similarly, that study showed this big difference in recurrence-free survival of 30 months for people who got adjuvant GEMOX compared to just 18 months. However, they again just missed statistical significance. And then BILCAP, which took 10 years to accrue, had 223 patients in resection versus resection plus adjuvant chemotherapy, and they were using capecitabine. These are impressive studies, 44 hepatobiliary centers, 200 patients randomized. And again, that was published in Lancet Oncology, which is a top journal. And again, big differences in overall survival, but just missed statistical significance. your authors seem to have the idea, challenge the idea that it's not reasonable to combine gallbladder intrahepatic and extrahepatic cholangiocarcinomas. Question 1, could you share if there's any clinical or biological or molecular evidence to suggest that these cannot be combined and are respectively quite different in behavior? This has always been a concern of combining malignancies, but recent trials have actually looked more to biology, such as mismatch repair tumors, and shown similar responses in greatly different named tumors based on the underlying biology. So I'll let you take that one first.
Sure. Thank you for your question and comments. Most of this in our point to highlight the inclusion of different cancers in the study is based off of clinical presentation and when the interception or the diagnosis may be made in these different cancers. So extrahepatic cholangiocarcinoma may present with painless jaundice, and gallbladder carcinoma may present incidentally on cholecystectomy, whereas an intrahepatic cholangiocarcinoma usually doesn't have any symptoms and may be diagnosed at a later disease stage. And the presence of microscopic distant metastasis may be different based off of where they are in their disease progression. So that's our point to say it may not be fair to lump these all into one category and study if adjuvant chemotherapy has an overall survival benefit if they're being intercepted at different points in their disease course.
Thank you. Your results mention that patients who received adjuvant chemotherapy presented with higher rates of clinical stage 4 disease. Is this accurate or maybe a typo? Typically, clinical stage 4 disease indicates metastatic disease and are excluded from adjuvant trials.
Yeah, we did exclude patients that had distant metastatic disease. However, the AGCC criteria has undergone revisions over the years that the NCDB years that we included. In clinical stage 4, they can also have a T4 tumor, which is periductal invasion. They could have a N1, which is a local regional lymph node, or a distant metastasis. So we did exclude the patients that had distant metastatic disease, but they were able to have a T4 tumor or a local regional lymph node and
that's
still be T4 or stage 4.
Okay,
Correct.
thank you for correcting or for clarifying that. Last question. Your paper carefully distinguishes that while your differences are not statistically significant, similar to the published randomized trials, it's heartbreaking. There's these huge, sometimes double survival rates for some sets. But again, you carefully pointed out in your manuscript, they're not statistically significant. So what would be your advice for a patient who, say, you resect a T4 tumor, you have negative margins, you have 1 out of 12 nodes positive? What would you recommend?
I think it needs to be a individualized discussion with the patient and present the data that we have, which is really, hey, we could try adjuvant chemotherapy. Your median survival may be a little longer. We can't say for certain, but your overall survival is unchanged. And so there may be a decreased quality of life that the patients experience with the addition of these chemotherapy regimens. And so it really needs to be an individualized discussion well, do you want quantity or do you want quality if there is a true difference? And I think that should be an individualized discussion with the patient.
Again, thank you for your manuscript, and you did a awesome presentation.
Thank you.
We have time for one more question.
So, Matt Chung from Grand Rapids. So maybe this is one of the reasons why surgery impact factor, if you will, hasn't gone up, because we like to study rare or uncommon diseases, right? I mean, if this was a medical oncology topic with common breast cancer, if there was a 2% survival benefit or survival benefit of 2 months, it would be published in New England Journal of Medicine, right? Landmark paper. So, I mean, I know what I would do. I'm getting adjuvant chemotherapy, right? There's a double in survival. Yes, it's not statistically significant, all of that. I get that. But I think we're too honest with the statistical, or too stuck on statistical significance in these rare diseases where we just don't simply have the N power.
Yeah. Yeah, unfortunately, if you look at the confidence intervals of our hazard ratios, it's so broad that it could be the reverse and it could be completely opposite because of how the statistical significant works out. And so, while it may appear to be a benefit, it could be, harmful. And we just can't say because of the statistical significance.
Thank you.
Thank you.
And staying on the same topic, intrahepatic cholangiocarcinoma, does liver-directed therapy provide effective local disease control? Being presented by Dr. Marshall Baker from the University of Utah.
Thanks. This is the green button, yeah. You're stuck, I'm the last, the last of the Mohicans, and thank the Society for the honor of presenting our work today. Chad, who is the medical student that was working with me for a year, couldn't be here because he and his wife had a baby 3 weeks ago, so congrats to Chad through the ether, and I'm taking credit for all the work that he did. But as Rachel just mentioned, sort of intrahepatic cholangiocarcinoma is a rare malignancy, but it's the second most common primary liver cancer that we see. Resection has for decades been thought to be the gold standard and the only therapeutic intervention that affords the potential for a patient to be cured of the tumor. But as Rachel also alluded to, many of the tumors that we see are presenting late without symptoms or with vague abdominal symptoms that develop only after the tumor is quite large or bridging anatomic structures that prevent it from being resectable. This sort of clinical environment has led to a drive to use local regional therapies to treat these tumors that are not surgical, and that includes a number of different forms of what we call liver-directed therapy. These include external beam radiation, catheter-based interventions such as transarterial radioembolization, chemoembolization, and bland embolization, and then also percutaneous methods of ablating the tumors, microwave and radiofrequency ablation. The problems that I think we face as clinicians trying to make decisions about how to treat these patients is that there are very few studies that actually compare the efficacy of these liver-directed modalities with sort of the gold standard surgical resection. And so we don't know honestly how effective they are relative to that intervention and whether or not they ought to be used in preference to surgery. So in that context, we were interested in asking this question: is liver-directed therapy efficacious as definitive treatment for patients with localized ICCA? How does it stand up against the gold standard surgical resection? And for about 25 years, the Huntsman Cancer Institute has been accruing clinical information on patients that are treated with ICCA in our system. We queried that clinical repository to identify patients treated for ICCA between 2010 and 2024. We were primarily looking for patients that had clinical stage 1 to 4A disease as staged by the AJCC7 staging system, and looking for folks that had treatment with liver-directed therapy or resection as primary local regional therapy. We excluded patients up front that had secondary primary malignancy. We did have one patient in the system that was treated with liver transplant. That one is included in our demographic and treatment comparisons, but not in our survival analysis because it was such a different case. We did exclude patients that had missingness for the data variables that we thought were of primary interest. So when you look at the number of patients that we had 199 patients that were treated for ICCA in our system that had a complete data set and that didn't have a second primary malignancy. Of those, 77 patients had clinical stage 1 to 4A disease, and 122 had distant metastatic disease at presentation. 39 of the ones that had local regional disease on their pre-op imaging studies were treated with liver-directed therapy as destination. 38 underwent resection, including that one that had transplantation. So we use multivariable logistic regression to identify factors associated with resection, Cox proportional hazard modeling to identify factors associated with overall survival, and then Kaplan-Meier analysis to look at disease-free and overall survival profiles for the different treatment cohorts. These are the comparison, numeric comparison demographics and clinical stage presentation. And it's important to note that there are some significant differences. The only one that's statistical is the age difference. The patients that underwent LDT were older by about 7 years. There were no race, ethnicity differences, no gender differences. The ones that had LDT did tend to have higher, more compromised ECOG performance status, and they had a higher clinical stage at diagnosis, even though those differences were not statistically significant. Important to, I think, recognize both when looking at our survival curves later. This is a univariate comparison of treatment characteristics. So interestingly enough, relative to Rachel's presentation, about 70% of patients had some form of systemic therapy before or after treatment with LDT or resection. Of the liver resections that we performed, about 60% were major hepatectomies. That means resection greater than 2 hepatic segments during their operation. And we had the 1 transplant. When you look at the types of LDT, I think you see some institutional bias. You know, the institution was very sort of prone to using external radiation for treatment of liver tumors prior to, 3 or 4 years ago. More recently, we're using TARE and catheter-based therapies. So there was the majority of patients that had LDT actually had external radiation as treatment, with about 30% having transarterial radioembolization. It's also important to recognize that those that had transarterial radioembolization, some were actually treated more than 1 time. So 5 or 6 of them actually had 2 or 3 rounds of catheter-based therapy before they stopped receiving local regional treatment. 5 resection patients had local regional therapy prior to surgery, had TARE for downstaging prior to resection, and 10 actually had radiation given after surgery for what we think is a positive margin or a close margin. These are factors associated with resection. You can see that age was associated with resection. Younger patients tended to be considered for resection. Older patients were not as often resected. These are factors associated with overall survival. In the Cox model, age was not, but ECOG status was associated with survival, as was use of systemic therapy and use of resection. But when we look at our survival analysis, I think particularly when you consider the fact that patients that had LDT tended to be older with more compromised performance status, the survival differences that we noted were not marked, and they certainly weren't statistically significant. This is overall survival, Kaplan-Meier unadjusted, and this is our Kaplan-Meier for disease-specific survival, which shows, I think, an even more parity between the treatment cohorts, resections in red and liver-directed therapy in black. So in summary, patients undergoing LDT for iCCA in our system were older, had compromised performance status relative to those undergoing resection. On Cox modeling, performance status, systemic therapy, and resection were associated with overall survival, but on Kaplan-Meier analysis, there was no significant difference in overall disease-specific survival between those undergoing LDT and resection as primary therapy. There are some typical limitations to our study, but I think in conclusion, LDT to me seems to offer local disease control that's comparable to resection, and it should be considered as an effective destination for treatment in iCCA. Thank you very much.
Thank you. And our invited discussant is Dr. Paul Kuo from the University of South Florida.
Thank you very much. So as I think upon this topic, I think back to 27 years ago when Marshall and I both had more hair, that I pimped you as an intern at Georgetown. So 27 years later, I now have the pleasure and honor of doing the same. So this is a small single center retrospective analysis. The authors note that propensity matching wasn't feasible due to sample size. But anecdotally, based on my own personal experience using liver-directed therapies, using microwave ablation and such, I think there's something very, very unique about what you're bringing up. So in the spirit of pimping Marshall, I have 15 questions for you.
And I'm gonna read them all out right now.
Okay.
No, actually, I just have a couple. First, was there any data on quality of life, length of stay, or costs between the two groups? And second, what are your thoughts? I know we talked about it now, the role of adjuvant therapy in this setting. Were there other comorbidities besides performance status considered? The liver-directed therapies, patients, as you point out, were older and surely had more medical problems. The key question is who should get what? Clear selection criteria will definitely be essential. And really, I think the most interesting part of this for me is what is it about the biology of either the tumor or the liver with regard to the tumor microenvironment of the liver that suggests that tumor-directed or liver-directed therapy is equivalent to traditional resectional dogma of cancer surgery? Again, thank you.
It's too many questions, and you had the same amount of hair back then. I had a little more, but not much. So what's the first, remind me of the first one again? Yeah, let me make you stand up because it's hard to get you here.
Yeah. Okay, so I sent these in a Word document to you
I
in the
know,
first author a week ago.
I know, and I have them right here, but I'm not very good at.
I could email this to you right now.
No, it's okay.
Okay. Did you have any data on quality of
Quality of
life,
life,
length of
yeah.
stay, or costs?
Yeah, let me take it one at a time and you can stand up, okay?
Thank you.
So yeah, I think this is the key thing that we don't have in our data, but I mean, I will tell you that I think from a person who's watched 1,000 patients go through this, the folks that had the LDT look a lot better than the surgery patients do in the early going. And even the robotic surgeries that we're doing a lot of these robotically now. They're staying a day in the hospital at least. It's oftentimes 2 or 3 days. So I think short-term quality of life is much better for LDT and cost is going to be lower. Even if you consider the fact that they need additional treatment, but that's just data that we don't have. Yeah.
The second question was, what about the role of adjuvant therapy?
Yeah, adjuvant therapy. So adjuvant therapy is one that I have a lot of personal bias about. I agree with what Rachel's findings were, is that I feel like adjuvant therapy benefits are very marginal. I think with BILCAP and Prodigy, these are studies that accrue over decades from many institutions because these tumors are so rare. They have very reasonable power, but the differences still don't achieve statistical significance. And so I don't think that adjuvant therapy is really something that has a big role to play at this point in this disease. I think immune therapy may change all that. The recent TOPAZ trial has really affected how we think about these patients, and we're starting to employ immune therapy even in a neoadjuvant setting now, and I think that will be determined. The efficacy of that in an adjuvant setting is yet to be determined.
The third question was, did you guys consider any specific comorbidities besides performance status?
Yeah, comorbidities, we have in our data set ECOG status only. And we can retrospectively go back into EPIC and look, but we haven't done that yet. I think the ECOG status grading is pretty good in our system, and I think it does reflect the comorbidities that we have in our patients. And you definitely see, I think, that playing in here. I mean, that to me is the big driver of the overall survival advantage that you see for surgery. They're younger and healthier patients.
Who should get what?
Yeah, I think that's a big question. And, the way we think about this now is I'm a surgeon and I'm sitting here thinking that the last 2 papers of this meeting are ones that I've had a lot to do with, and they're both on non-surgical topics. But I'm still a believer. I think patients get a psychological benefit out of having the tumor taken out. I think that's something that's going to play into your quality of life assessments as we do those over time. When you get to year 5 and your cancer's out, you stop following somebody. I think there's a quality of life benefit that they get from that. So we still tend to look at surgery as the first question. Are they resectable or are they not resectable? And if they're not resectable, we think about alternatives. If they are, we think about should we resect it? And I think the larger patients, the ones that have a question mark of nodal involvement or ditzels in the lungs, we tend to treat those folks first and then restage and then consider LDT versus surgery. And that's what we're doing now, but we just don't have the granularity of data at this point to really know exactly what to do. Yeah, and then the last question, I will remember that one. I mean, I think it's another great question. I personally think it's a lot of direct cytotoxic effect. We use a lot of transarterial radioembolization in our group now and external beam radiation prior. And those, I think, are really methods that just kill the tumor directly. We do believe that there's an interplay that's going to happen between immune therapy and cytodestruction, meaning that you're going to get antigen presentation locally that's going to result in a better effective immunotherapy. But I think that LDT primarily is sort of local regional destruction of the tumor. And that's why I think you see things like TARE being more effective than TACE. The TACE folks almost always have some viable tumor on follow-up imaging. The TARE in patients seem to have more likelihood of having complete tumor destruction as they're treated.
So last thing, and I didn't read it out previously, but it's in the document. So given that the two groups are different in terms of comorbidity, do you think that liver-directed therapy in your resectional candidates would generate better outcomes than resection?
Yeah, I think this is another great question. I mean, we tend to do that now. This data is a little old, but we tend to, with larger tumors where there's a question about local regional extent, nodal involvement, disease that we kind of want to watch for a little bit, but we ultimately think are good candidates for resection. They're getting, so these are tumors that are 5, 6, 7 centimeters in size. Maybe they've got a large portal lymph node that we can't biopsy or that's been biopsied and is not definitively cancer. Treat them with systemic therapy for a while, restage them, and then treat them with LDT prior to resection. And we've had a number of patients that have actually had complete responses on their resection, which leads to the question of, do we need to resect them at all? But I feel like we're probably getting to a point where we're getting better results than if you just resect up front without some kind of treatment prior to resection.
Thank you. Our next session is the presidential address, so stick around.